So it's great to be here. I'm glad we could finagle the schedule a little bit for my transportation issues, and I'm glad that I have a chance to just share a little bit of few thoughts from the national perspective for county and city health departments, which is what Nature represents. So first of all, I want to thank Daniel Stein and Stephan Kanye again, and the Stewards of Change team for including me, and also Johns Hopkins for hosting us, obviously. So I'll just start by saying we are really here, and I think that the kind of whole trajectory about this discussion in social determinants of health has gotten us to this place in this place in time because, in a nutshell, we understand that context matters. We understand that place matters, education matters, income and poverty matters, housing matters. We understand that access to health care matters, but it's not the full picture. And in fact, if you look at the average number of times a person will have some contact with a healthcare professional, the average American may have 2 touch points per year with a healthcare professional. And if that American has some health issues, some ongoing chronic health conditions and such, they may have a contact with a pharmacist, a retail pharmacist, maybe 6, maybe 8 times a year to fill their medicines and to touch base in terms of side effects and the like. But we also know that 365 days a year, that person has to live in their home, on their street, on their block, in their neighborhood, and in the broader community. So, in fact, what we've learned is that proximity to and access to health promoters, health sustainers, and health providers really determines, I wouldn't even say health, I'd say the health expectancy of a community. What can they expect in terms of their personal trajectory of health? Because when you're talking about the determinants of health itself, we understand that individual decisions, and we understand that genetics plays a role, but in terms of the big picture, the health expectancy, it really is about those drivers in that context. So context can also be looked at or talked about in terms of an ecosystem. And in my experience in spending 25 plus years as a public health practitioner at the local and the state and the national and the global arenas, my experience has shown that the story is always the same. Every single time it is the same, and that is the net influences of the ecosystem will support one or two things. It will support either health and wellness, or it will support disease and premature death. And that's the picture. That is the formula. That's what I've learned, and that's what I see time and time again. So when we're looking at those communities with poor health outcomes, we're really looking at a community with some deficits in terms of structural issues, policy issues, environmental issues that conspire together to make the healthy choice not really a viable choice for those folks in those communities. And not to discount altogether individual choice and things like willpower, we have to understand that it's really the ecosystem that makes it easier, difficult, or sometimes impossible for you to try to put yourself and your family on that trajectory of health and wellness. And so, taking the ecosystem framework, in the U.S., important partners in the ecosystem is what I would call the governmental public health enterprise. So the governmental public health enterprise is an important player in the ecosystem nationally, in the ecosystem ultimately at the individual level. So if we're talking about the federal government, where a lot of the money or resources come through either CDC, through their categorical programs, or through their development of the community guide, or the Center for Medicare and Medicaid Innovation Center through the state innovation models, or through HRSA, through their FQHCs, or the community guide, or the clinical guide, or others. That's very, very important, and it has the potential to influence the ecosystem at the local level. A lot of that money and a lot of those resources actually go to the state level. And I know ASTO is here representing. I'm a former ASTO alumni, and they represent the 61 states and territories. And sometimes it's easier and more expedient for some of those resources to go right to the state level with the hope and with the promise that those will eventually trickle down to the local level. And that's where NACCHO has a role and a responsibility. So NACCHO, again, the National Association of County and City Health Officials, is really the leader, the partner, the catalyst, and the voice for nearly 4,000 local health departments across the country. And what we understand is that health ultimately is profoundly local. So on my way here, I saw a woman, and she was running through the train station. She had two kids behind her, two daughters behind her, and the woman was eating a Cinnabon, something very sweet, high carbohydrate, high sweet goodie, and she was obviously overweight. And then her two kids behind her were eating the same sweet, soft goodies, sugary covered goodies, and they were overweight. And they must have been 5 and 7 years old. And so I thought about that in terms of the modeling, in terms of that personal behavior, in terms of the nutritional value. And then I thought a little bit broader than that. What are going to be the chances? What's going to be the health expectancy of these young kids growing up in an ecosystem, in an incubator, with modeling such as this, in a community that maybe has some of these deficits? And how is that going to determine their trajectory in life? And again, it made the point that health ultimately can be profoundly local. So in essence, what we do at NACCHO is we support the local health departments and their mission in protecting the health and improving the lives of the folks in their jurisdiction. It might be a city, it might be a county, it might be a town health department, and we basically help them to help influence the context for health in the communities that they are responsible for. In general, what NACCHO does is we do things around policy, around advocacy, direct technical assistance, best and promising practices, toolkits, and the like, capacity building for local health departments, be it their infrastructure or their IT, their information sharing, interoperability, sharing with other players in the space. We have a very robust public health transformation portfolio because we know that health reform is transforming, but also it's affecting and impacting public health as well, because they're going to have to start thinking differently about how they do their work. Helping to infuse health informaticians into their work so they can better understand and mine their data, liberate their data in some cases to the public, so the public can be a partner in helping to assess and prioritize some of that data. Sharing that data with other healthcare personnel in the space, be it shared service models or payment models. We help to influence how they do their work and try to stand them up so that they can be more viable in their mission. Specifically in the space of social determinants of health, we have had a number of projects recently that are really focused on assisting local health departments in leveraging what they know about the community around them. So if it's about context, these folks in the local health department have been doing community health needs assessment. They have been gathering and bringing people together, be it FBOs or CBOs or healthcare delivery partners, to really assess and prioritize, crunch the data, and then prioritize what are going to be the drivers of health or disease in that community that they can really collaboratively tackle. We've also been spending a lot of time recently in terms of supporting models for public health to really work with healthcare delivery. So we understand that since we've added that aim of population health improvement, we've got the attention of and the hard work of healthcare delivery specialists who are trying to ask themselves the question, how can we improve the population? And how can we think of population health broader than just our patient population or our attributable population or our catchment area population? So we've been supporting health departments in really standing up and really bringing their value proposition to this understanding. Because health departments have a lot of expertise in terms of population health. They are and have been neutral conveners. They are data stewards. The information for the community comes there to the health departments. They collect and analyze it. They can be connectors, facilitators, and ultimately we want them to be the most valuable partner in this space as public health and population health experts work with healthcare delivery. We've also been supporting them in ways of looking at their business models and the value add around that. What types of clinical services should they abandon? What types of other things should they amplify and the like, so that they can be valuable and viable options in the community, in the ecosystem. And then specifically in terms of the social determinants of health, we have been doing a number of things in terms of the educational space, e-learning, and other resources to really help them understand the importance of the social determinants of health and how it impacts their communities, and as they bring these cross-disciplinary folks together to really help to emphasize what's going on. We have a number of courses. Some of you may have heard of the Roots of Health and Equity course that we've been doing for many, many years, and just trying to help bring their knowledge up and their information up around how it impacts the work that we do. So I'll just end with a story in terms of how this can actually happen, how collaborative approaches can really bend the arc for members in a community in terms of their health and wellness. I spent some time, as mentioned, in Chicago, but I was the state health director based in Chicago. And there's a community, a Latino community in Chicago, where through the use of the health data and the understanding of some of the rates there, the disease rates and disability rates, it was understood that they had very, very high rates of obesity, and not surprisingly, very, very high rates of diabetes as well. So what then embarked was a collaborative approach that involved the healthcare delivery, that involved the community health clinic, FQHC, that involved the city health department, that involved a lot of players to really tackle this problem and this issue. And what it resulted in were teams that kind of navigated the community and did door-to-door screenings for diabetes with the residents in that community. When they found someone that had a questionable finger stick, a questionable high sugar or borderline sugar, obviously that led to the direct referral into healthcare, where either a diagnosis could be made of diabetes or prediabetes, and some education could be given. So there was health education classes, classes around diabetes, classes around eating properly. There were classes around cooking. They worked in partnership to develop some free or low-cost gyms where folks can come and do free Zumba classes, free aerobics classes, and just kind of change the whole trajectory of the health expectancy of that community. And as you might imagine, a few years later, the rates began to come down. And not only that, the community and the residents in that community were more informed. And what we had done, in effect, was change the context in which they lived in to give them a better chance of health expectancy going forward. So that's just a small sample. What we do at NACHO is we gather these samples across the nation in terms of these best practices that are happening, especially with healthcare delivery and with local health departments. We try to recognize them. We try to do through awards programs and things, and highlight and emphasize and elevate these stories of success, and actually promote and disseminate these stories of success. So in closing, I'll say once again, individual personal behavior is important, but context is the most important thing, and together we're here so we can really learn better ways to affect and impact the ecosystem in which residents reside in. Thank you.
One of the things we're talking about is how do you reapportion the investment to prevent upstream elements versus the downstream elements. We talked a little bit about that.
Yeah.
And having your view now as from a national perspective and also from the state level, recognizing that is utopian in some regards, how would you characterize the opportunity to make that change now? So people are,
sure.
What's necessary to make that happen?
Well, there are a lot of opportunities, and I think that when you bring local public health to the table, state public health to the table, you can enhance those opportunities. I think what we're learning through the triple aim, having population health improvement be one of those important metrics, is that healthcare delivery has not historically thought about what happens outside of the walls of the facility. They want you to come back, they want you to be compliant, this, that, and the other, but then you got to go back into your context. So now there's opportunities for them to start partnering with population health or public health experts in terms of how we can synergize what's happening in the clinic to what's happening in the environment. Sometimes this takes the expression of regional health collaboratives. So you're bringing healthcare delivery in with public health and other members of the community to actually look at the data, to actually prioritize things, and then to elevate synergistic strategies to improve things. So if you're looking at obesity, for instance, what's going to happen in the clinic from that provider is some counseling, right? What's going to happen in the community is going to be things around health awareness, things around bike pathways, walking pathways, lighted parks, joint use agreements with schools, things like that. So it's kind of the 1-2 punch, and that's the opportunity. But in terms of apportionment, money basically dictates behavior. And so what we have to do is, and what we did in Illinois for some time, is thought about ways to incentivize local health departments their contribution to keeping people healthy and out of the hospitals, and trying to make sure that healthcare delivery got some reimbursement or did some reinvestment in the local health departments to actually do that, so that they're just not getting credit for the good work that's happening from the local health departments, but they're incentivized to actually engage in these exercises and these joint collaborative exercises in terms of planning and execution, and that they're reinvesting some of that money back to support the infrastructure, be it data or otherwise, in the local health departments. And so that's really kind of the sweet spot going forward, I think.